And we are back. This is going to be the last part of Chapter 8. We are still looking at our circulatory system, and we're going to go ahead and switch our focus now over to the mammalian heart and figure out what's going on over there. All right, so last we spoke, we were taking a look at the different heart models, including a fish heart. We talked about the amphibian heart. We talked about the reptilian, non-crocodilian heart. We took a look at their chambers and how blood flows through it. So now what I want to do is go over and take a look at what's happening with birds and mammals and their four-chamber heart. In part 1, I had mentioned to you that the four chambers consist of two atriums on top. They will be the ones that will be receiving the blood as it's entering into the organ, and then they will go ahead and move the blood into the lower chambers, which are going to be called the ventricles. The purpose of the ventricle is not only to receive blood from the atrium, but also move it out of the heart, whether it's going to go over to the pulmonary system if it's on the right side of the heart, or over to systemic circulation if it is the left side of the heart. Now, it's very important to keep the oxygenated and deoxygenated blood separate in mammals and birds. So one thing that we're definitely going to be utilizing is this very thick wall called the interventricular septum. You can see it by my little red arrow right here. This wall will keep the two ventricles completely separated from each other. I had also mentioned to you before, and I definitely want to remind you, the fact that the left-hand ventricle is slightly thicker when you take a look at its wall composition of myocardium compared to the right side. And part of that will have to do with the pressure differences that we're exposed to. Since the left ventricle has to generate enough pressure to do circulation throughout the entire body, while the right ventricle will only concentrate on generating pressure for the pulmonary system, we see that the left will be thicker to correspond with the fact that it has a higher exposure to pressure differences. So the left side will always be thicker than the right side. This only refers to the pressure difference. We still see that the same amount volume-wise of blood will enter each ventricle at the same time. It is extremely important to balance out blood volumes on both sides equally to prevent edema from occurring. Another item that I want to show up on the slide is the fact that we want to ensure what we call one-way blood flow, meaning that we want the blood to enter to the atrium, go into the ventricle, and then go back outside. We do not want the blood to go in reverse. So for instance, we don't want it to go from the ventricle into the atrium. We want to have this one-way blood flow. In order to ensure this, we're going to go ahead and utilize valves. You are going to have two different valves in the mammalian and bird heart. You will have your AV valves, your atrioventricular valves, which will lie between the atrium and the ventricle. And you will have your semilunar valve, which will control movement out of the ventricle. So here in green, I'm going to highlight for you the AV valves. As you can see, they will go ahead and regulate movement between the atrium and the ventricle. You have two of them, one on the right-hand side and one on the left-hand side. The right-hand side is called the tricuspid valve. The left-hand side is called the bicuspid or mitral valve. They are called tri and bi because they're made out of different cusps, which are pieces of connective tissue. So the right side has 3 cusps and the left side has 2 of them. My apologies when I say the term cusp. My lisp really gets in the way on that one. So the right-hand side, you can go ahead and call it either the right AV valve or the tricuspid valve, but the more popular name is tricuspid. And then the left-hand side is going to be either the mitral or bicuspid. Both names are acceptable. A really quick way to easily remember right versus left is basically utilizing the terms rat versus lamb. So which animal are you looking at? A rat stands for right atrium tricuspid, and lamb is left atrium mitral or bicuspid. So that'll keep track of what side you're looking at. Both of the AV valves will regulate motion between the atrium and the ventricle. The semilunar valves are going to be able to regulate movement out of the ventricle. So then what we see happening is if we come over to the illustration, we're going to be able to see them right over here. And you're going to have on the left-hand side, you're going to have your aortic semilunar valve. And on the right-hand side, you're going to have your pulmonary semilunar valve. So right is for the pulmonary and left is for the aortic, which all makes sense of our definition of pulmonary versus systemic circulation. Now, those of you who are looking at the picture might also notice that there is quite a structural difference between the AV valve and the semilunar valve. When you look at your AV valve, you're going to see these little like threads that come down from it. These are called cordia tendineae. Some of you might know it as stenoneous cords. These cords are only found in the AV valve, and they're basically going to connect with the papillary muscle that you see right here, and they're going to be tugging at each other, and that's then how the valve is going to open and close. And I had mentioned to you before that the AV valve can either have 3 or 2 cusps that make it up. In the semilunar valve, there are no cords, so there's no cordia tendineae, and all of them are going to be a tricuspid. So all of them are going to be made out of 3 little cusps. And in fact, if you peek at this picture, I'll show you a larger one in 1 second, you can see the 3 pieces working together. There is also no valve that regulates motion into the atrium, okay? So you'll only have valves between the atrium and the ventricle, and from the ventricle to the outside. And really the easiest thing to do is to kind of discuss blood flow through the heart. And in that way, what we'll do is we'll take a look at all the different arteries and veins, chambers, and valves that you come across. But before we do that, I want to discuss about actually what is causing the valves to open and close. Like, when do they know when it's time to open up, when is it time to close? We know that the main purpose is to prevent any backflow, right? We want to keep the blood moving forward. So what does it operate on? And for that, I'm going to switch over to a little illustration. So here we go. So let's take a look at our AV valve. So these are our rat versus our lamb. Tricuspid on the right, bicuspid on the left. Okay, so what we see happening here is that the valve will open based on changes in pressure. Changes in pressure. And when it does so, it will allow blood to always flow from a high pressure point to a low pressure point. What does that mean? Well, what I'm going to see happening is, as the blood comes into the atrium starts increasing in volume, and when it increases in volume, it increases in pressure. And at a certain point, the pressure in the atrium is going to be higher than the pressure in the ventricle. And when we see that happening, the valve is going to open up. So the valve will open up and blood will go gushing out of the atrium and go from a high pressure point to a low pressure point, which is the ventricle. Now, as you can imagine, as the blood goes gushing into the ventricle fills up. And as the ventricle fills up, what we see happening is that it now starts to have a high pressure point because the blood is pushing against the wall of the chamber and it's filling it up. And at a certain point, we get to the part where the pressure is higher in the ventricle than it would be in the atrium. Now, at that point, what we see happening is that blood would then have a tendency to flow backwards because it likes to flow from high to low. However, the whole purpose of the valve is to prevent that from happening. So we see that the valve will close off when the pressure in the ventricle exceeds the pressure in the atrium, thereby preventing backflow from occurring. And it does the same thing on the left-hand side as it does on the right-hand side. So if you want your AV valves to open, then the pressure in the atrium needs to be higher than the pressure in the ventricle, because that will allow you to go from the top to the bottom chamber. And if the AV valves close, that means that the pressure in the ventricle was higher than the pressure in the atrium. And we're closing it because we don't want blood to flow back into the atrium. We want it to only flow one way. So our next stop would be to get blood to flow out of the ventricle and into either the pulmonary arteries or the aorta, so it can go over to the lungs or it can do systemic circulation. So we're going to see that those valves, the semilunar valve, will follow the same exact procedure. So here are my semilunar valves. So I'm talking about my aortic semilunar valve on the left and my pulmonary semilunar valve on the right. So you can see them on the picture. They're right over here, my little semilunar valves. And what's going to control their opening? Once again, a change in pressure. So come back over here to B, and it says on the left-hand side, it says the semilunar valves are open. And the reason they're going to open is because the pressure in the ventricle is going to be higher than the pressure in the blood vessels that are outside. I'm going to call these the great blood vessels. And when this happens, we see that the valves open and blood goes once again from high to low, so it goes gushing out. And as the blood goes gushing out, the ventricle starts to empty out. And when the ventricle empties out, what happens to the pressure? I hope you say it lowers, and you're completely correct. As the ventricle starts to lose blood, the pressure starts to drop. And at a certain point, we see that there is higher pressure in the vessels than there is in the ventricle. So blood would have a tendency to go backwards. Because remember, blood likes to go from high to low. So we don't want that. So what are we going to do? We're going to close the valves. And when you close the valves, you prevent backflow from occurring. So guys, it's all about pressure differences. You want to remind yourself that you always want to go from a high pressure point to a low pressure point. And the goal is to go from atrium to ventricle to outside the heart. So we never want to go backwards. So if you want your semilunar valves to open up, that means that the pressure inside the ventricle needs to be higher than the pressure in the blood vessels, whether it's the pulmonary arteries or the aorta. And if your semilunar valves are closed, that means that the pressure in the blood vessels was higher than the pressure in the ventricle. Okay, because we're always going to go from high to low. And remember, our goal is to prevent backflow. So if you see that there's a potential that blood is going to flow back into the ventricles, then you want to close the semilunar valves. If you see there's a potential that blood is going to flow back into the atrium from the ventricle, then you want to close your AV valve, your atrioventricular valves. The actual opening and closing of the valve happens completely silently. There's no mechanical sound that it makes. However, what you do hear if you were to take a stethoscope and listen to your heartbeat is you hear the lub-dub sound. What you're hearing there is the fact that when your AV valve closes, the blood that's trying to flow back into the atrium will hit the closed valve. And when it hits the valve, that's the sound that you hear on the stethoscope. Same thing happens with the semilunar valve. When the blood is trying to flow back into the ventricle, when you close your semilunar valve, it hits the wall of the closed semilunar valve and it makes the sound. So we like to say when you listen to your heart, it makes a lub-dub sound. Lub-dub. Lub is for the closing of your AV valves. Or I should say it corresponds with the closing. It's not the actual valve closing. It's the fact that blood hits the back of the closed valve. And dub, my goodness, you'd think I would get better by this writing. Dub corresponds with the semilunar valve closing. Once again, it's not the physical act of closing the valve. It's the fact that the blood hits the back of a closed valve, which then makes the sound. Okay, so if you come across a true or false question, and it says to you, for instance, true or false, the physical closing of the valve is responsible for your heart sound. I hope all of you go false, because the actual physical closing of the valve doesn't cause the sound. It's when the blood hits the closed valve, the turbulence of the blood hitting that closed cusp is what makes the lub and the dub sound. Okay, so remember, when it comes to your valves, you have your AV valves, you have your semilunar valve, and they're all going to be opening based on a pressure difference. They always want to go from high to low, and their main goal is to prevent backflow from occurring. So we can now take all this beautiful knowledge that we have gained, and we can talk about how we can explain a red blood cell traveling throughout your entire body with a heavy emphasis on the different chambers and different blood vessels and valves that they would come across in your heart. So let's take a look at this picture. And we're going to take a nice deep breath and we're going to walk ourselves through it. We're going to start on the right-hand side of the heart because the right-hand side is all about collecting the deoxygenated blood. And we're going to keep an eye on our color code. Remember, blue is deoxygenated, and those are going to be our veins. And red is going to be oxygenated, and those are going to be our arteries. Remember, veins bring blood back. Arteries carry blood away from the heart. There will be an exception to the rule. So that's why I want to remind you of what most of the guidelines tell us. Okay, so let's start over here by good old-fashioned number 1. And number 1 is telling us that we are in our right atrium. Now, how did we get to the right atrium? Well, we utilized the vena cava. The vena cava is the largest vein you have. So you have the superior that's above it, and you have the inferior that's below it. Both of them will empty out into the right atrium. Once your blood is in the right atrium, we're going to go ahead and go into the right ventricle. But in order to do that, we have to pass through a valve. What is this valve called? That's going to be our rat, right? That's our little reminder. So that's going to be our right AV, aka our tricuspid valve. From the tricuspid valve, we're going to go into our right ventricle. And then we're going to go through our semilunar valve. And what's this semilunar valve called? Hopefully you guys are saying pulmonary semilunar valve, and you would be completely correct in there. It's going to go through the pulmonary semilunar valve into our pulmonary trunk, which is this big blood vessel right here. The pulmonary trunk will give rise to the pulmonary arteries because it's going to carry blood away. You have 3 of them. 1 on the left, 2 on the right. Okay? Now, the pulmonary arteries, they are arteries because they carry blood away from the heart. Where is it going? It's going over to the lungs because we want to drop off CO2 and pick up oxygen. Do you notice anything different about the pulmonary arteries? They are blue, not red. Yes, why are they blue? Because they're carrying deoxygenated blood. So remember, the goal of an artery is to carry blood away. However, this artery is carrying away deoxygenated blood because it has to go over to the lungs. So do not be surprised when you look at your illustrations, whether it's in lecture or lab, and you're used to seeing arteries as being red, and all of a sudden you see a blue pulmonary artery. It all has to do with the fact that it's carrying the deoxygenated blood from the right side of the heart on its way over to the lungs. All right, so we get to the lungs, inhale, exhale, drop off that CO2, pick up that oxygen, and then now how are we going to return back to the heart? Well, we're going to have to go over to the left side, right? And in order to get there, we're going to have to enter to our left atrium. And the left atrium will be reached by going through our right and left pulmonary veins, because veins return blood back to the heart. Here's my little left atrium, right over here. They return blood back to the heart. Now notice how the veins, what color are they? Red. So the color coding between the pulmonary arteries and the pulmonary veins is switched from what you expect, and that's because they normally would carry deoxygenated versus oxygenated blood. That is also switched. Your pulmonary artery, which you would expect to carry oxygenated blood because it's an artery, is carrying deoxygenated blood. And the pulmonary vein, which is returning from the lungs and coming back to the heart, is going to be carrying oxygen-rich blood. So it's going to be nice and red instead of its traditional blue color. Okay, so from the left atrium, which valve are we going to encounter next to get into our left ventricle? We're going to encounter our lamb. That's going to be our left atrium, which is going to give rise to our mitral or bicuspid valve. That brings us over to the left ventricle. From there, we're going to go over to our aortic semilunar valve, which isn't really pictured that great, and that's because it lies directly behind the pulmonary semilunar valve. So we're going to pass through our aortic semilunar valve. We're going to go into our aorta. And from the aorta, we're going to do our systemic circulation, and we're basically going to infuse the rest of our body. And we are going to go ahead and be good to go, and only to repeat the entire cycle again by once we drop off our oxygen to pick up our carbon dioxide and enter back through our veins, our vena cava, and then we go right back into the right atrium, and we do this all over again. On average, every 0.8 seconds, your body is beating, the heart is beating. And it's doing this over and over and over again. So I know you guys hate this when I do this, but let's do this again. Let's make sure we get the blood flow down, because I would love to ask you several questions about this on your upcoming exam. And I really do believe that if you know the blood flow in the heart, it really does help you with knowing all the different chamber and structure names. Now, obviously, you can go ahead and pay attention to the right-hand side where everything's kind of typed out and explained step by step. But for those of us who are more visually inclined, feel free to follow the numbers on the heart. So I'll go through it again, and let's see if you can kind of assist me on your end as we flow through. So we're going to start on the right-hand side, okay? So blood is going to enter the right atrium through the vena cava. From the right atrium, we're going to go over to the tricuspid valve into the right ventricle. From the right ventricle, we're going to go through the pulmonary semilunar valve into the pulmonary trunk and away with the pulmonary arteries. This is going to bring us over to the lungs. From the lungs, we're going to return through the pulmonary veins into the left atrium, through the mitral or bicuspid valve into the left ventricle. From the left ventricle, we're now going to pass through the aortic semilunar valve, which, as the name indicates, will bring us over to the aorta. And from the aorta, we complete our systemic circulation, and we do it all over again. Please spend some time, take a look at this, because like I said, on your exam, I would love to ask you some questions about blood flow, what chamber do we get to next, which valve do we use, which blood vessel do we use. So if you have any questions, comments, and concerns, definitely reach out, but put a big old star next to this slide because you want to become very familiar with it. I also want to point out over here, this is the cardiac cycle of fish hearts. You're going to have a very similar concept in the fact that it is going to utilize valves to prevent backflow. Notice how on your PowerPoint it says that they're going to open and close according to pressure differences, because it's always going to go from a high pressure point to a low pressure point. And as I had mentioned in part 1, the 4 chambers of the fish heart are going to be the sinus venosum. That's the one where the blood enters, and then it goes into the atrium, into the ventricle. And notice on your illustration now how you also have valves that are regulating the flow. And from the ventricle, it's going to go into the bulbous arteriosus. Now remember, that one does not contract. However, it does have an elastic component, and that is all going to have to do with the fact that it can respond to the gush of blood that's being secreted out of the ventricle when the ventricle does its systolic motion or its contraction motion. So it can dampen the pressure differences as the ventricle contracts and relaxes. I also went ahead and wrote down for you that the sinus venosum chamber is the one where the heartbeat will be initiated by a group of pacemaker cells. So this will allow the heart to beat consistently. Here is a look at the entire cardiac cycle put together. And now what this picture shows us is not only how blood flows from one chamber to the next, it also shows you the importance of the valves, and it also shows you how the systolic and diastolic terminology will come into place. And this is very stereotypical of both a mammalian as well as a fish cycle. Now, a lot of times when you do your cardiac cycle, because the ventricle is larger and able to receive more blood, we're going to kind of start off by taking a look at what happens when the ventricle is relaxed. Because when it's relaxed and it's in its diastolic motion, that is when it's going to be receiving blood from the atrium. So go ahead and look on top left for the box number 1. And what we see happening here is that when the ventricle is in its diastolic motion, so it's nice and relaxed, we see that the pressure is low. The pressure in the atrium exceeds that of the ventricle. So what does that mean? That means that my AV valves are open, so blood can flow from the atrium into the ventricle, okay? And it does this passively, meaning that the ventricle doesn't have to do anything. It just has to kind of sit there in its relaxed mode. Now, eventually, the blood is going to fill the chamber to the point where the blood starts to accumulate in higher levels in the ventricle. And at that point, what we see happening is that because your heart is myogenic and consistently beating, that will correspond with the fact that the atrium will go ahead and enter its systolic phase. So when the atrium does its systolic phase, it contracts, and when it contracts, it still has a higher pressure point than the ventricle, and it will use this contraction to kind of squeeze out any additional blood that it might have. So you can see right here in step number 2, this will be the end part of the ventricle receiving blood. And that is because the atrium will first do it passively in step number 1, and then secondly, it will go ahead and contract, allowing additional blood to flow into the ventricle. By the end of step number 2, you have reached what we call our end diastolic volume, and this is for the ventricle. So at the end of its relaxation, how much blood has it accumulated? And just for fun, let's add some numbers to it, just so we can kind of play around with it. So let's say that the ventricle at the end of step 1 and step 2, so from receiving blood passively and also through contraction of the atrium, it has a total of 170 mLs. And this is going to correspond once again with your EDV, your end diastolic volume. And this is only for the ventricle. This applies to both the left and the right. So both of them will have 170 ml each at the end of relaxation, at the end of the diastolic motion. Now, the fact that it has accumulated so much fluid means that its pressure has built up as well. So we're going to see that there's going to be a few things that are going to happen. The first thing that's going to happen is you're going to have to close your AV valve, because we don't want the blood to go back into the atrium, right? The pressure in the ventricle at this point is higher than that of the atrium. That's why we're closing the AV valve. But look what's happening with your semilunar valve. They're still closed. Why is that? That's because the pressure in the ventricle is not higher than that of the blood vessels yet. Okay, so what we have is we have this awkward period of time where the volume in the ventricle stays the same, because it has nowhere to go, and that's because both of the valves are closed. We like to call this isovolumetric contraction. Isovolumetric means the volume stays the same. We're calling it contraction because the ventricle is starting its systolic motion. So it's starting to contract. See the little yellow arrows? But it's not contracting fully yet. It's only when it contracts to the fullest that the pressure in the ventricle shoots up, and it becomes higher than that of the blood vessels above it. So when it's in full ventricular systolic motion, you have ventricular ejection. And the reason you have that is because at this point, the semilunar valves are going to open, and blood is going to go gushing out of the ventricles into either the pulmonary arteries or into your aorta. And as the blood goes gushing out, we are going to go ahead and be able to calculate our stroke volume. Stroke volume is how much blood you've ejected. So let's say you've ejected 70 ml. Okay, so 70 ml goes flying out of the ventricle and it goes into the blood vessels. Now remember, as you're losing blood, the pressure starts to go down. So eventually you're going to get to the point where not only is the ventricle starting to do its diastolic motion, it's relaxing, it's also lowering its pressure point because it has less blood, which means that what are we going to do? We're going to close off the semilunar valves because we don't want backflow to occur. So when you do that, and now you're once again in a situation where the ventricle is closed off by both ends and no blood is coming in, then we have our last volume to report, which is going to be our end systolic volume. So at the end of contracting, how much blood do I have left? And in this case, it's going to be 170 ml minus the 70 ml that I lost during my stroke volume, or I should say gave away, which means I have 100 ml of blood that's going to be left there. The ventricles are never bare. There will always be some blood in there. Part of that is because it will contribute to the pressure point that naturally needs to occur in the chamber. All right, now once the ventricle has done its diastolic motion, that it will sit there and start receiving blood from the atrium. Once the atrium has enough blood to open up the AV valves because of the higher pressure change, and then once again blood will be added passively, the atrium will contract, adding some more blood, and then the ventricle will do its isovolumetric contraction, followed by its full systolic motion, meaning it can eject the blood out into the great blood vessels because the semilunar valves are open, and then followed by a ventricular diastolic or diastole motion, meaning that it's relaxing, first isovolumetric because both of the valves are closed, and then the AV valves will open, allowing blood to once again start gushing into it. This is a continuous cycle, and remember, whatever is happening on the left-hand side is happening on the right-hand side. We always want to stay balanced. So take a look at the slide. It says in birds and mammals, most of the blood that comes from the ventricle will be filled passively during diastolic motion. So while the ventricle is relaxing, it's just passively receiving it from the atrium. When the atrium does contract, it does add blood, but not as much as it was passively adding to the system as the AV valves were open. This is not always the case. So for instance, right over here on the middle part of the slide, it tells you that in fish and amphibians, most of those receive blood by the fact that the atrium is contracting. So there's different models for everybody, but the end goal is to always get blood to go from the atrium into the ventricle. Keep in mind that I've mentioned this to you before, that the pressure is not the same left versus right. Because the left ventricle has a higher surface area to cover, it has to distribute it throughout the rest of the body. That pressure point is going to be a higher start. So it will push blood out at a more forceful pattern. The right-hand side is going to encounter some resistance, which is going to slow down its flow. Part of it has to do with the fact that it has a lot of capillaries that are supplying blood over to the pulmonary side, over to the lungs. The other part has to do with the fact that your lung is very delicate due to their functioning units. The little alveoli, they're very fragile in their tissue, so we can't have a high pressure point on the right-hand side because we want to make sure we don't do any damage to the actual gas exchange units. This is also why the left side is thicker than the right side when you look at the myocardium of the ventricles, because anytime you work out a muscle, it becomes larger. So since the left side has a higher pressure point, it'll be the thicker side versus the right side. Now, once again, this only has to do with pressure. As you can see from the final statement on the slide, it says the circuits will have the same blood flow. So if there's 200 mLs on the left, there's 200 mLs on the right. Everything has to stay the same because if you make it imbalance, you get edema. So for instance, let's say you have a patient who comes in and their pulmonary circuit isn't properly functioning. The right side of the heart is very weak. It can't respond to the blood flow. It can't keep up with the same amount as the left hand. Well, what we see happening is if that happens and the right side starts shutting down, then most of the time we see that the blood will stay on the left side because it can't return to the damaged side. So we get what we call systemic edema. Blood starts to pool in different places in the body. So the patient is going to note swelling, for instance, in their legs, some in their abdominal cavity, anywhere really that's systemic related. And that's because the blood can't effectively return to the right side of the heart because it's damaged. What would happen if you damage the left side of the heart? So what if your left atrium and your left ventricle can't keep up with demand? Well, in that case, blood is going to hang out on the right side of the circuit. It's going to hang out in the pulmonary side. This is very dangerous because you can get pulmonary edema. So some patients call this, who've experienced it, say that they almost have the sensation of drowning, of asphyxiating, just because there's so much fluid that hangs out within the lungs. It can be very dangerous either way. So we always want to make sure that the same amount of blood is balanced on either side, because you don't want to have edema that accumulates. All right, so this little illustration just kind of shows you from a pressure aspect the difference between the right and the left. Look at this. So much higher pressure point on the left-hand side, and all of this has to do with the fact that the ventricle on the left side just has been exposed to such a high pressure point, all to kind of keep the blood circulating throughout the entire body system. Now, one thing that I also want to point out, and we've discussed this before, is the fact that the heart is myogenic, because remember, each of the little cardiomyocytes, the little heart cells, are able to spontaneously do their depolarization, action potential, and repolarization. So they don't require nerve input to keep the heart beating. In fact, if you ever were to remove a fresh mammalian heart, as long as you make sure that it has enough sodium, you can literally cut it in little pieces, and the little pieces will beat by themselves. Obviously, we want our heart to function as a unit and have the strong compulsive force. So what we see happening is that we need to have some type of mechanism that we can get the heart cells to beat in unison. And that is then where your pacemaker cells are going to come in. Your pacemaker cells are just a group of cardiomyocytes that sit in the right atrium of the heart. And these cells will form our SA node, our sinoatrium node. They are going to be our pacemakers, which means that they're going to be the ones that are going to have the initial start of the heartbeat, because they are going to be the ones that are going to be the initial ones to depolarize and get excited. And they can do so because they have lots of F channels. Remember the funny channels? When we previously talked about muscles, the funny channels basically mean that it can quickly depolarize the cell because it can fluctuate the sodium coming into the cell and its response to calcium. So it has an unstable resting membrane potential, very easy to excite, and because we want the heart to beat in unison, we see that we're going to rely on the pacemaker cells to get it started, and from the pacemaker cells, it's going to radiate throughout the entire atrium, down the ventricle, and as the end result, we'll have the entire heart that's excited. And we see that then why the atrium has to contract before the ventricle will. It all has to do with the myocytes depolarizing in a very distinctive pattern, starting with the SA node in the right atrium. So what we can do is we can hook up our patients to an electrocardiogram, an ECG or an EKG, depending if you're going to do the English or the German spelling. And what our EKG will do is it's able to record these electrical impulses of the depolarization, action potential, and repolarization. And we then know, based on our knowledge of the heart, that the electrical signal that we see will be followed either by a systolic or a diastolic motion. It's very important for me to point this out to you. When you look at an EKG, you don't actually see the heart beating. You see the electrical currents that are associated with the depolarization, action potential, and repolarization stages, so the changes in membrane potential. We know that following those stages that the heart will respond by either doing a systolic or a diastolic motion. So for instance, let's go ahead and take a look at some of the illustrations on this PowerPoint. Let's take a look at a normal EKG. Now, in a normal EKG, you would expect to have 3 deflections. You would have what we call a little P wave, a QRS complex, which looks like a little spike, and then you have a T wave. Those are the 3 parts that you would come across. And I will let you know that this is a highly oversimplified explanation of an EKG because there are much more minute little events that take place, but because we have already covered so much, I don't want you guys to get overwhelmed. So for the EKG for us, I want you just to focus on the P wave, the QRS, and the T wave. Those are the 3 things I want you to keep an eye on. Now, when you see the P wave, and you can take a look at the picture that's up here, what we're seeing is how the depolarization and action potential is being affected in the heart. So if you come over to your illustration, notice how everything's going to start by the pacemaker cells. Those are going to be sitting by your right atrium. And notice how on the picture the area has turned green because it's showing you that your SA node has depolarized and it's starting to spread its excitement over to another node, the little AV node. Either way, it's spreading its excitement throughout the entire atrium. And that first change of depolarization is noticed by the P wave. So on your PowerPoint, I wrote down the P wave is when your atrium starts to depolarize. And that all has to do with the fact that your SA node fires off. And what happens when the atrium depolarizes? What action do you get? It's going to go ahead and contract. It's going to go ahead and do its systolic motion. Now keep in mind that it contracts after it depolarizes. So that means when you look at your EKG and you see your patient has done the P wave, right after the P wave is over and all the depolarization has spread across the atrium, that's then when the atrium contracts. So you know that that action is the end goal of changing the membrane potential. Now, what happens next? So the atrium has done its systolic motion. Well, 2 things happen next. The first thing is that your excitement is going to start spreading down the interventricular septum over to our Purkinje fibers, and it's going to start exciting the ventricle. And when the ventricle gets excited, because it's larger than the atrium, it's going to form the QRS complex. So that's our second wave. So our QRX complex is all about the ventricle depolarizing and getting exciting. And at the end of the QRS, the ventricle is going to contract. It's going to do its systolic motion. Now, at the same time that this is happening, your atrium above us is repolarizing and relaxing. This signal is obscured because the atrium is so much smaller than the ventricle. However, we know that it's occurring even though that signal is being masked by that large QRS spike, courtesy of the larger ventricles. And then the last part is going to be your T wave. Your T wave is all going to be about ventricular repolarization, so it's resetting itself, and eventually it will relax through its diastolic motion. And then you'll have this little straight line. This is called a quiescent period. The quiescent period is when all 4 ventricles are relaxed and they basically start all over again with the firing of the SA node. Now, don't think that that takes too long because like I said to you before, on average, we have a heartbeat every 0.8 seconds. So the quiescent period is only about 0.3 seconds, while the rest of the time is spent on the P, QRS, and T wave. Now take a look at the illustration labeled B, and what do you think is happening over here? It's called ventricular fibrillation. This is what it looks like when your patient is having a heart attack, and what you're seeing is that the individual heart cells are still contracting and relaxing, so they're still doing their depolarization and repolarization, and that's what you're picking up with the squiggly lines. It's a very scientific term, they're squiggly. Notice that you don't have your P, QRS, and T. Why? Well, because since the cells are pumping or contracting individually, they are not able to contract the atrium and the ventricle in unison. So you don't have one strong contraction, which means you don't get your typical P, QRS, and T complexes. This also explains why a heart attack could be so dangerous, because even though the cells are still individually discharging and pumping, they're not generating enough pressure for the heart to act as a pump and keep up with blood flow demand to the pulmonary and systemic system. So that's also one of the reasons why they'll go and they'll get a defibrillator and they'll shock the patient. It's almost like recharging a battery, hoping that with that electrical shock will give enough time for the pacemaker cells to take over the initiating of the heartbeat so that the atrium and the ventricle can once again contract in unison. So here's that picture of the electrical conduction system, just enlarged. It's the same one that you saw above. See my little heart beating? Notice how the beat starts in the atrium in the top and then goes to the ventricle at the bottom. And this one just kind of highlights the fact that everything starts with the SA node. So it's going to cause the depolarization of the atrium, and when the atrium is fully depolarized, we get our P wave, and we know that's going to correspond with the atrium contracting, and then that excitement is going to spread down the His bundle, which is by the interventricular septum, through the Purkinje fibers on the side of the ventricle, and when the ventricle is fully depolarized, we get our QRS complex, and that electrical charge we know will lead to the ventricle contracting. And last but not least, we'll get our T wave, and that is when the ventricle is repolarizing, relaxing, and then we have a short little quiescent period where we just kind of have everything relaxed, and then we start it all over again. So here it is in illustrative form. So go ahead and take a few seconds. Take a look at that yellow electrical charge moving from your SA node over to the bottom of the atrium where you have an AV node, down the interventricular septum, up the sides of the ventricle. And notice how after the electrical current has passed, that's when you have your contraction. So I can't mention this enough that when you look at your EKG, you're noticing the electrical current. And after the electrical current has occurred, that's when the cells respond by contracting and relaxing. So doing its systolic and its diastolic motion. Okay, now just a few more things before we finish off chapter 8. One thing that I definitely want to mention is cardiac output, CO. Cardiac output tries to figure out from a mathematical sense how hard the heart is working. Okay, it takes a look at how much blood do you pump per unit of time. It is calculated by taking your heart rate times your stroke volume. So the average heart rate is about 75 beats per minute, and the stroke volume is about 70 mLs. So let me just go ahead and pull up my calculator real quick because I'm not that good at doing this just on random. And let's go ahead and calculate. So the average heart rate is about 75 beats per minute, and if I multiply that times 70 ml, which is the average amount of blood that I release every time the ventricle contracts, then the number I get is 5,250 mLs. So that's equal to about 5 liters of blood. Now, on average, humans have anywhere from 4 to 6 liters of blood. It all has to do with body size and other things like age and exercise and all that other stuff. But in essence, that means that your body is able to pump the majority of volume every minute of your so each red blood cell comes into contact with the heart at least once every minute. How cool is that? So that's your cardiac output. It's your heart rate times your stroke volume. And based on that, we can make different diagnoses. So for instance, if you see the term tachycardia, that is the diagnosis if your resting heart rate is above 100 beats per minute. So you're not exercising, you're just sitting there watching your favorite TV show or listening to my soothing, lispy voice. There you go. So if you find your heart rate being higher than 100 beats per minute on a regular basis, that can lead you to be diagnosed with tachycardia. We got to be careful with that because that could put a lot of stress on the heart cells. If your heart rate is abnormally low, you can be classified with bradycardia. bradycardia is usually when your resting heart rate is below 60 beats per minute. It doesn't always have a clinical application. The reason I say this is because we see, for instance, in people who are very athletic, that their ventricle size will be enlarged compared to, I'm going to say, people who don't exercise as much. So that means that when their ventricle contracts, their stroke volume will be higher than normal. It will be above the 70 mLs of blood. So because they're releasing more blood with every heart rate, their cardiac output will allow them to lower their heart rate to still keep up with the demand. So the heart doesn't have to pump as often. In fact, I remember reading an article that at the peak of his fitness, Lance Armstrong, his resting heart rate was anywhere between 32 to 35 beats per minute. So that's almost half what you normally would expect. All of this has to do with what they call ventricular hypertrophy, the fact that because he was such an aggressor athlete, we won't talk about the doping scandal, but because he trained a lot, his ventricle had enlarged hypertrophy, which allowed it to accommodate a higher stroke volume. So here is what we call the Frank-Starling effect. The Frank-Starling effect basically tells us that when we take a look at our cardiac cycle, depending on what we receive from the atrium will correlate to what the ventricle will give away. So in essence, your end diastolic volume will be corresponding with your stroke volume. So they're related to each other, which means that if my end diastolic volume is higher because I've received more blood, that means that my stroke volume will be higher as well. And this all has to do with the mechanics of being able to form your cross bridges, and obviously that the heart will try to regulate itself so that it has a nice consistent cardiac output. If your end diastolic volume goes down, then your stroke volume goes down as well. So basically one controls the other, and that's what Frank-Starling effect says. We also want to definitely point out, I've mentioned this before, because of the thicker layer of muscle, a higher amount of elasticity in the arteries, they are an excellent pressure dampening system, and this has to do with the fact that they have to be able to correspond to the fluctuating pressure changes as blood comes gushing out of the ventricle. So they should be able to quickly adjust, and what we see happening is that when the ventricle contracts, and the blood is ejected, we see that the arteries will adjust to this rush of blood by quickly vasodilating. And when the ventricle then relaxes, in order to keep up with the pressure changes and the fact that the blood flow will lessen, is that the arteries will quickly vasoconstrict. And by doing that, having this elasticity and being able to change the lumen of the arteries, it's a fantastic way that we can dampen not only the pressure differences, but it will also prevent us from getting the sensation of syncope, like we're about to pass out, every time the pressure goes down from when the ventricle relaxes and the blood flow goes down as well. This is part of what you calculate when you take someone's blood pressure. You basically want to figure out how much pressure they're exposed to during ventricular systolic motion versus its diastolic action. The systolic motion, when it's contracting, will have a higher pressure point than when it's relaxing in its diastolic motion. And the closer you take it to the heart, the higher the volumes are, just because of the excessive pressure that they're exposed to from the starting point of the systolic motion of the heart. When it comes to the veins, the blood pressure is a lot lower in the veins. And part of that is because the veins are so far away removed from the pumping action of the heart. So what we see happening is that the veins will not only have a low pressure point, but they will also need to utilize valves. Very similar to what we saw in the heart, the valves are going to serve to make sure that there is unidirectional flow. We only want the blood to be collected upwards towards the heart. We don't want it to come back down on the veins. So for instance, when you're standing, all that blood in your tippy toes and in your foot and in your leg, all that deoxygenated blood has to travel up against the force of gravity to make its way ever so closely to the heart so it can do its venous return. It can return that blood back to its overall flow. So in order to assist with this, we're going to see that our valves in the veins will close off as the blood passes through, so that the blood just keeps moving and it doesn't go back. And in fact, when you have someone who comes to you with varicose veins, that usually means that when you look at their legs, you see this abnormal blue pooling. That's easy to identify, and that's usually due to the fact that they have a valve that is not properly functioning. So the blood is trying to backflow, and it will sit there in the valve, allowing for all that blue fluid to accumulate. In fact, anytime you look at your body and you see those tiny little blue lines, if you're fair-skinned, you see it a little bit easier. That just means that that's a particular valve that you have, a particular vein that's running close to the surface of the body. So remember, they carry deoxygenated blood, so it's the blue blood. When you prick yourself to collect blood, it doesn't really matter what type of blood vessel you prick. Well, obviously they want to prick the arteries, but when they prick it, the blood isn't blue, because the minute you make a puncture hole in your skin, you expose oxygen to the blood, so it turns red, in case you were wondering why they never drew blue blood from you. Going back to the slide, my apologies, I kind of went off topic there. What you see happening here also is that in order to assist the veins in collecting the blood back and returning it to the heart, it will rely on the skeletal muscle and the respiratory pump. The skeletal muscle is important because the muscle will surround the veins, as we see in the pictures right here. And as the muscles contract, they're almost massaging the veins, allowing the blood to easily flow up against the flow of gravity. And then, of course, the valves will come into play as well to prevent the backflow. The respiratory pump means that as the blood gets closer to your thoracic region, the fact that you are inhaling and exhaling creates a pressure difference that almost acts as a suction that allows the blood to be easily returned over to the vena cava. There are no valves in your arteries. They don't need the valves because they obviously have exposure to a high pressure point from the heart, and they can quickly do their vasomotion to compensate for that. Valves will only be found in the veins. And then last but not least, I don't think it surprises anybody that your blood pressure will alter or be changed depending on your overall location of your body, meaning if you're sitting or if you're lying down. Changes of gravity all has to do with that. So that is why often when you do a blood pressure, it just kind of gives you a quick little snapshot of what's happening. And like I said, they tend to do the blood pressure systolic over diastolic, close to the heart, because that's where you have a high pressure point. But some people, instead of doing a traditional blood pressure, they like to do an MAP or a MAP. That's a mean arterial pressure point. And what that does is it basically allows you to take blood pressure at different parts of the body. So you would go down the arm, down the leg, and also in different positions. So you would have your patient lie down, sit down, and stand up. And what that's going to allow you to do is to give you a nice cumulative effect of what pressure points your body are being exposed to. And it will also show you the usefulness of your baroreceptors. You have baroreceptors within the heart by the blood vessels that are continuously monitoring your blood pressure, and they're able to quickly adjust your heart rate and vasomotion to go ahead and compensate for any abnormal low or high blood vessel. A good example of this is if you've ever overslept and you find yourself to kind of wake up and quickly jump out of bed, you might get that lightheaded feeling that you might have had, and that's basically because when you got up so quickly, blood drained from the brain downwards in a much faster pattern than it normally would. Your baroreceptors weren't able to react so quickly, so you felt lightheaded. Now, for a lot of us, we'll just kind of like stand there, close our eyes, and before we know it, we open it up, a few seconds goes by, and we're good to go. And that's because the baroreceptors notice, they respond, and they restore the blood pressure back to normal. Alrighty, that is all I have for you guys for Chapter 8. I hope you had as much fun listening to it as I had narrating it. The cardiovascular system is truly one of the unique and most fascinating systems that we have in our body. And I really like the fact that we could do a comparison across different animal models. Some of you might not agree with me. All right, I will go ahead and stop. This is our last chapter before we take our Unit 2 exam. So if you have any questions, definitely let me know. Get comfortable with the exam material. And then the next time we'll meet, we'll start discussing our 2 chapters for exam number 3. Bye, everyone.